respected senior professionals and dear friends. So in the next few minutes, I would like to talk on management of dyslipidemia in the Indian perspective. So dyslipidemia is nothing but an imbalance of the lipids. So we often get the lipid profile for most of our diabetes, hypertension, coronary artery disease, CKD and etc. So it's a very common investigation we order for the to know the exact lipids in our body. And while seeing the lipid profile, we spend a lot of time on the cholesterol values, LDL cholesterol, triglycerides, HDL, and don't stop at this level. Please add non-HDL-C cholesterol also. So that is nothing but subtraction of your HDL from the total cholesterol. You will get the non-HDL-C cholesterol. That is equivalent to your apolipoprotein B, which is the most important atherosclerotic lipoprotein in our body. So don't think that lipids are very, very bad for our body. They are very good. They are the very important energy sources in the form of the triglycerides. And the lipids, they are very much useful for the signal pathways. And they are all your steroid hormones. The precursor is from the cholesterol. So the cholesterol is also an integral part in all the cell membranes, lysosomes, and also your other skin particles. The lipids are very, very important. See, when seeing these dyslipidemias, so it definitely why we are interested in dyslipidemia part is to protect our people from the cardiovascular diseases, peripheral vascular diseases, and also from the cerebrovascular disease. Nothing but the macrovascular diseases. See, you all know that it's a major independent risk factor for the coronary artery disease. You know the different risk factors like diabetes, hypertension, obesity, smoking, strong family history, aging factor, hypoproteinemia, hypoalbuminemia, and also hyperbilirubinemia, and also hyperuricemia, and also your microalbuminuria, ankle brachial index, and also these are all the calcium scores in your coronary arteries. So these are all the emerging risk factors are there. And out of all these things, the dyslipidemia is one of the important risk factors to cause the coronary artery disease. Because it causes atherosclerosis and also other cardiovascular events like heart failures or arrhythmias, etc. Now the cardiovascular diseases have become a growing burden across the globe. You all know that the most important cause of the death in the diabetes is the myocardial infarction, and the most important cause of the death in almost all the young individuals is the vascular death. And again, the dyslipidemia could be one of the important reasons for these premature deaths. Developing countries like India alone that accounts for about 80% of the global CVD mortality. And this is the recent study, ICMR India study. So that gives the dyslipidemia in Indian picture. And if you see here, the dyslipidemia in India is about the 79% of the subjects having at least one lipid abnormality. So that shows that nearly 80% of our people are having one form of the dyslipidemia abnormalities. And if you see these dyslipidemias, some people will have the hypercholesterolemia, some people will have the hypertriglyceridemia, and some people will have the low HDL-C cholesterol. Unfortunately, 90 to 95% of the Indians are having the low HDL cholesterol, which is an important factor for our dyslipidemias. So here the 79% of Indians have at least one lipid abnormality with about 70 plus with reduced HDL. So HDL is good. It should be more than the 40 in the males and more than the 50 in the females. And very few drugs will act on the to elevate your HDL. And of course, statins will elevate. Fibrates also will elevate. But in fact, the niacin can rise the HDL in a big way. But unfortunately, that is not the palatable because most of the people on niacin therapy, they will develop the gastrointestinal side effects. So the only way to elevate the HDL is our physical activity. So the good physical activity, good sleep pattern, good dietary habits, more fiber, etc. So definitely that increases our HDL-C cholesterol. And triglycerides and LDLs are very, very important lipoproteins. So responsible for our premature atherosclerosis. If you see the Indian prevalence, India has seen a rapid increase in the prevalence of all the cardiovascular diseases. So because of the increased incidence of the diabetes and hypertension, because of more and more environmental factors like urbanization, modernization, etc. And CAD manifests almost a decade earlier in India than in the Western. That is very, very important. If you see any non-communicable diseases, the India is getting at least not 1 decade, maybe 2 to 3 decades earlier to the Western population. Even today, we are seeing a lot of the people at the age of 18 years, 19 years type 2 diabetes. At the age of 21, 22 with accelerated hypertension, maybe stage 3 hypertension, So a lot of our people are getting the PTC and CABG even at the age of 30 plus or less than the 40 years. So that shows that CAD is important manifestation of our dyslipidemia population. Incidence of the CAD is increasing most rapidly among the patients younger than the 40 years of age group. So you can imagine what will happen when they have the CAD at the age of 35 or the 40. So not only are the personal problems, the family and also the society is also at loss because of this young onset of these non-communicable diseases. See, if you see the 10 to 25% of the MI in India, they occur before the age of the 40 years. More than 50% of the CAD associated deaths in India occur before the age of the 50 years. And if you see the racial and ethnical differences in dyslipidemia and the pattern, so when compared to the Chinese or Japanese or Koreans or Mexicans, unfortunately, Indians are having the more and more incidence of these diseases at an younger age group. So the dyslipidemia in Indians different from the Western population in forms of the higher prevalence of these diseases. And if you see the therapeutic goals for the low density lipoprotein cholesterols depending on the cardiovascular risk. So whenever you see a fellow in front of you in your chamber, so you assess whether the cardiovascular risk is at a low or medium, high or very high or critically high. But unfortunately, most of our people, they fall into the group of either high or the very high risk. Very few people in the low and the moderate risk. If you see the people with the high risk or the very high risk, they are the diabetics, they are the hypertensives, they are having the familial hypercholesterolemia, and also they have more and more target organ damages. So atherosclerotic cardiovascular disease. So in history of the atherosclerotic cardiovascular disease, they comes under the group of the very high risk individuals. So in all these individuals, our LDL goal is less than the 70 or the less than the 55. So the most important take-home point from our today's discussion is you have to keep your LDL levels for most of our population to less than the 70, in some of the population less than the 55, and whom in the less than the 55, maybe the 30 is also possible when the fellows are having the past history of the atherosclerotic cardiovascular disease or the diabetes with the target organ damage. So what are the major risk factors, atherosclerotic cardiovascular risk factors? Age more than the 45 years in the males and more than 55 in the females. A family history of the premature atherosclerotic cardiovascular disease, smoking, high blood pressure, and low HDL-C cholesterol. So without knowing that, most of all of us will have at least 3 or the 4 or the 5 of these major risk factors. Because age is ever growing subject and we can't change our parents. And low HDL-C, almost all the Indians will be having the low HDL-C cholesterol. So these 3 are very much there in all our population. Suppose if you are a smoker, and definitely the 4th criteria is also there. And most of our people are hypertensives because 30 to 35% of the Indians are the hypertensives. So it shows that most of our population, when they are entering into our chamber, they are with the major risk factors. And if you see the other high risk factors, already told you the diabetes, and then the CKD stage 3 or the 4, and then the familial hypercholesterolemia, and the coronary calcium score more than the 300, non-stenotic carotid plaque, and the lipoprotein little a more than the 50 milligrams. See, this is also very important in some of the population where the lipid profile looks like the normal. The total cholesterol is maybe 150, the triglycerides maybe 140, LDL maybe 40 or the 50, but still these people have the recurrent atherosclerotic cardiovascular diseases or acute coronary syndromes. And if you check the lipoprotein A, in most of these people will be more than the 50 or more than the 60 and the 70 also. So this is also very important investigation to be done in the recurrent atherosclerotic cardiovascular individuals to rule out the main cause of this dyslipidemia. And I already told you that high risk and very high risk and extreme risk. Extreme risk means the coronary artery disease with very high risk of the past history of the recurrent atherosclerotic cardiovascular diseases. In all these individuals, we have to keep the LDL-C target for this group is less than the 30. So all these years, our target of the LDL-C cholesterol is more 100 or 80 or 70. Now it should be less than the 55 or even the less than the 30 is also possible. It is very, very difficult to reach the target of 30 or the 40 without the intensification of the statins. So most of our people, they need ezetimibe adding to your high intensity statins or maybe the bambodenic acid. And some people may also require PCSK9 inhibitors also to reach your LDL target of less than 30, especially in the people with the recurrent atherosclerotic cardiovascular events. So macrovascular complication, this is the steno 2 study, intensive and the conventional. So clearly shows that intensive study, there will be the risk reduction of the death by 46% and the CV causes death by the 57%. And LDL, how low? So if you see the primary prevention, your goal should be around the 57, and for the secondary prevention, around the 30. That is also very important take home point. So for the primary prevention, don't be happy with the 80 or the 90 of the LDL. Your goal around 57, maybe less than the 70 is your goal, must be your goal for the primary prevention. Whereas for the secondary prevention, it should be around the 30. See the here, in both the patients, the LDL level is 100 milligrams. But in one, the large LDL, whereas other group with a small and the dense LDL. That is very, very atherosclerotic. So even though the LDL appears to be 100 or the 90 or the 80, but it is the number of the LDL particles and the density of the LDL is very important. So the smaller the number and also the denser the LDL, that shows more atherosclerotic. So this is the diabetic dyslipidemia. So characterized by the three things: elevated triglycerides, low HDL, and small and dense LDL, even though if it is not an elevated LDL. See how to treat these elevated LDL group. See, most important is the lifestyle measures. So your dietary approach and your regular exercise and smoking cessation, and not the restriction of the alcohol, but the moderation of the alcohol is the right to have a good lifestyle measures. And then the optimal control of the diabetes and hypertension, because these two are the very important reasons for the premature deaths. And your goal must be more than the around the 50 milligrams. And if you don't get this with high intensity statin means your rosuvastatin 20 milligrams to 40 milligrams and atorvastatin 40 milligrams to 80 milligrams. So if you don't get this level, then you can add the HDMI, which controls or which inhibits the cholesterol absorption from the intestines, but it is a weak lipid lowering drug, but it acts better in the presence of your statins. If still the LDL goal is more than the 50, then you have the two options. So you can add the bempedoic acid that is easily available right now in the market in the form of about 180 milligrams, or you can go for the PCSK9 inhibitor, provided if your goal is the 30. These are monoclonal antibodies that improves the LDL receptors in the body, so that the LDL cholesterol concentration in the blood will be lowered by improving the tissue level of the receptors of the LDLs. So this is your triglyceride management, and you can have the two groups here. In one group, less than the 500 of the triglyceride. In the other group, more than the 500 of the triglyceride. Some of our people will have 1000, 2000, 1800. Almost it looks like the serum almost looks like very curdy. So that shows that cheese like. So that is about the hypertriglyceridemia. See, in some of the individuals where the diabetes is not under control with HbA1c 13, 14, 15, if they have the hypertriglyceridemia, so for the fear of the pancreatitis, we can start with the fibrates. Otherwise, a simple control of your blood sugars alone will reduce the triglycerides. So what I mean to say is, see, isolated hypertriglyceridemia in the presence of uncontrolled diabetes, please control the blood sugars first, and automatically the triglycerides also will come down. And if the triglycerides at a higher level, even after the control of your blood sugars, after you're reaching your euglycemia, then you can try to start with your statins or the fibrates, etc. Suppose if the less than the 500 of the triglycerides, so most is the dietary approach and then the exercise, and then you can add the statins. Even for the triglycerides also, the statins work, because the statins, they're not only reducing the LDL, they also reduce the cholesterol, they also reduce the triglycerides, and they also elevate the HDL. But the reduction of the LDL is more with the statins, about the 50 to 60%, and reduction of the triglycerides is little with the statins, maybe 15 to 20%. And the elevation of the HDL may be 5 to 10% of the statins. And if you see the fibrates, the reduction of the triglycerides to the tune of 60 to 75%, and the reduction of the LDL may be 10 to 20%, and the elevation of the HDL is much more than the statins. So in such people where there will be the hypertriglyceridemia and hypercholesteremia and more elevated LDL, you can include the combination of the statins plus the fibrates, so for the fear of the pancreatitis and etc. So the lipid association of the India recommendations, so both fasting and the non-fasting lipid profiles are important. For routine screening, a fasting lipid profile is not mandatory. So you need not advise all our population to get the fasting lipid profile. because the postprandial lipid profile, the only value which is abnormal is the triglycerides. So if your LDL, your cholesterol, your HDL, they are the normal in both the fasting as well as the postprandial. So most of our people, most of our life, true fasting means maybe for 4 to 5 hours only. So for that reason, I don't mind to get the lipid profile even at any time of the day or the night. Direct LDLC cholesterol is the preferred because most of our labs, they get the cholesterol, they do the triglycerides, and they calculate the LDL, they calculate the HDL. So it is always not good to have a calculated LDL and calculated HDL. So you should have a lab where they get the direct LDL, direct HDL, direct cholesterol, and direct triglycerides. So that gives a valuable information about these things. Otherwise, in the presence of the hypertriglyceridemia, the LDL levels may be wrong, the HDL levels may be wrong also. So the direct test is very, very important. Very few labs in Kakinada, they do all the 4 direct. Most of the labs, they do only cholesterol and the triglycerides, and then they calculate the LDL and the HDLs. See, all patients that hypertriglyceridemia should be evaluated for atherosclerotic cardiovascular risk and maintain the triglycerides less than the 150, preferably less than the 100. So as well, I told you that lipoprotein A more than the 50 is always dangerous. Even more than the 20 is also more risk for the atherosclerotic cardiovascular disease. See here, the recurrent atherosclerotic cardiovascular disease, despite the optimal lipid lowering treatment, you have to order for the lipoprotein small a measurements. So these are the foods to eat: omega-3 fatty acids rich in the fish, high fiber foods, olive oil, vinegar, garlic, onions. So that is the reason West Bengal people, most of our people, they take the fish, and the incidence of the myocardial infarctions are very, very less in Calcutta. If you see the cath labs in Calcutta, hardly 35 to 40. Whereas in Hyderabad, more than the 250 or 300 cath labs are there. So in Hyderabad, more cath labs because of the biryani, because very less cath labs in Calcutta because of the increased consumption of the fish because of the high omega-3 fatty acids. So other foods to avoid are the sugar and the refined products. So the packaged and the processed foods, hydrogenated fats, trans fats, conventional dairy products. So these are very much important. You all know these foods to be avoided because we have to advise the complex carbohydrates. We have to avoid the simple carbohydrates. More and more protein is important for the Indian patients, even they are in the CKD. And then the more and more polyunsaturated, monounsaturated fatty acids, more omega-3 fatty acids, very, very less saturated fats, no trans fats. So that should be the ideal food one has to be taken to avoid these non-communicable diseases. So the physical activity is very, very important. Don't think that obese people are more prone for the atherosclerosis. Physical inactivity itself is a big risk factor for the atherosclerotic cardiovascular diseases. So the physical activity, at least 10,000 steps a day, not less than the 5,000 at least. So this is a very important physical activity. So a simple walking is also preferable. The Western book says that 150 minutes a week and 5 days in a week. But for Indians, every 7 by 7 walking and 60 minutes a day is very, very much required because of increased insulin resistance for us. So for a given BMI, we are having the more and more insulin resistance when compared to the Western population. So that is the reason physical activity 60 minutes a day, 7 by 7 is a must for most of our diabetic and hypertensive and adult Indians. So the lipid lowering drugs, already I told you the HMG coenzyme reductase inhibitors, they are the statins. The 2 statins are available, atorvastatin and the rosuvastatin, and there is no role of the low intensity statins in Indian diabetics or hypertensive. Only we use the moderate intensity or the high intensity statins. Moderate intensity statins means rosuvastatin 5 to 10 milligrams and 20 to 40 is the high intensity. Atorvastatin 10 to 20 is the moderate intensity and 40 to 80 is the high intensity. So these HMG coenzyme enzyme is a very important thing. So if you see the pathology, so if you see the physiology of the cholesterol metabolism, acetyl coenzyme A will be converted to mevalonate and mevalonate will be converted to the cholesterol. And this HMG coenzyme A inhibits the production of the mevalonate so that the cholesterol production will be obstructed. So that is the reason the cholesterol values will be reduced by using these statins. Bile acid sequestrants, we are not often using it, but tigurinic acid, already I told you, that is the first lipid lowering agent entered into the market way back in 55 or the 60s, but is not acceptable by most of our population. Fibric acids, we have the fenofibrate 140, 180, 200. So that's very good to reduce the triglycerides and increases your HCX. So rosuvastatin is a superstatin when compared to the atorvastatin. It reduces the cholesterol concentration in circulation, decreases the triglycerides, increases the HDL cholesterol. So the statins will act on all the three, but mostly the LDL and the cholesterol. Rosuvastatin also have the pleiotropic effects. They shown the effects independent of the lowering the lipid. That is the reason statin is a must for all the diabetics and hypertensives and high risk individuals. Reduction of the C-reactive protein is another important advantage of using the statins. It reduces the oxidative stress and it has an anti-inflammatory effects. So the fibrates are very useful. Bile acid sequestrants, agitidones, this is agitamide, a weak lipid lowering drug. Adenosine triphosphate citrate lysase inhibitors, there is a bempedoic acid. So they reduces the risk. So statins, they increase the risk of the new diabetes is also there, but the risk is more when compared to the gain. So gain is more when compared to the risk of using the statins in the diabetics. Uranus study compared the rosuvastatin with the atorvastatin says that rosuvastatin is much superior to the atorvastatin. The same thing, the Jupiter study for the primary prevention. So use the statins for all the diabetics. LDL more than 160 treated. High sensitive CRP more than the 2 that shows the vascular inflammation also will be reduced by using the statins. So in summary, cardiovascular diseases are the most prevalent cause of the death and disability in both the developing and the developing countries, especially in India. Managing dyslipidemia among the patients for both the primary and the secondary prevention. See, the aspirin for the primary prevention now the $1 million question. A lot of the people will be having the intracellular hemorrhages. But the statins, they are must for both the primary as well as secondary prevention. For the primary prevention, your goal is around 70, whereas for the secondary prevention, your goal is less than the 50. Statins and the statin combinations are widely used for the dyslipidemias. Bempedoic acid is a new molecule and also exhibits the good results. It can be combined with the statins also. So thank you very much for your patient hearing.